Um, we ended with blood pressure, and when I sent you the email on Friday, I sent 3 different videos. I sent the one where they were doing a Doppler. I sent one, when I say oscillometric monitoring, that is indirect because you're not in a catheter. You're on the limb, and when you puff up the cuff, that gives you an indirect measurement of blood pressure. And an oscillometric monitor can be by itself. It can be part of an ECG monitor. That just means the type of blood pressure you're doing is oscillometric measurement. And oscillometric gives you all 3 values: systolic, diastolic, and mean. When I say Doppler, that is indirect, but a Doppler uses a sphygmomanometer and the little, a cuff and a crystal, but that only really gives you systolic pressure. Some people say they can hear the diastolic and then calculate the mean, but that's very difficult. So most of the times if we use a Doppler, we just get a systolic, which is great. I mean, a systolic number is good. And then if I say direct blood pressure, that is the catheter. I sent you a video of, let me sip something. I sent you a video. They were placing an arterial catheter. It was actually the dorsal pedal of a horse. They do use the facial and the mandibular in a horse, but in that video they were using the dorsal pedal, probably because they were working on the head. If they're working on the head or neck, then you have to use a distal artery. So I just wanted you to know the difference between direct and indirect and what types of monitors measure that. And then obviously, I did talk about using color, mucous membrane, and CRT to give you an idea of blood pressure or feeling a pulse, but all of that is subjective. All of that is just an estimate. I'm not going to really go over central venous pressure. We don't use this a lot during anesthesia. You have to put a catheter in the jugular vein, and that's not a regular IV catheter, that's a special jugular catheter. Okay, so the sphygmomanometer, Michaela, was I don't think it's in a picture. Nope, it's not in a picture. I gotta get a picture of it. In the video, the little thing they're pumping up with the dial, that's the sphygmomanometer. If you're going to do the cuff measurement, that's an oscillometric. Now a Doppler, you have to use a cuff to occlude the artery, but the sphygmomanometer, or the oscillometric, is the cuff is hooked up to a machine, and the cuff or the machine pumps it up automatically and does the reading for you. So hopefully that answers your question. But central venous pressure, we're looking at the pressure in the venous system, and we have to put a catheter in the jugular vein to do this. And the main reason when we do CVPs, and I've only done a handful in my career, most of the time on hospitalized patients in the intensive care, is to monitor for fluid overload. Because if they have excess venous pressure, there's no pressure, there shouldn't be much venous pressure because there is no pumping from the heart. It's just returning. It's a low pressure system coming back to the heart. So, but if you have too many fluids in a dog, it would put excess pressure on the venous system. So that's when so I don't know if you talked about this in fluid therapy at all. This is more of a critical care, emergency type care thing. I've done it occasionally in a patient during surgery, but most of the time when I've done this, and you would get training on how to do this because it's a specialized technique. But really, central venous pressure is monitoring for fluid load. Okay, no, you're fine, Sarah. Thanks for getting in and telling me. Okay, so I've talked about cardiovascular monitoring. Believe it or not, that's all cardiovascular, which is hugely important. The other thing is we have to make sure we're monitoring how our patient is oxygenating, because everything we do is affecting, anesthetics depress ventilatory drive. How deep they can breathe, how often they can breathe are automatically depressed. So we have to make sure that the patient is able to still oxygenate the body in a depressed anesthetic state. So the way we do this, pulse oximetry we're going to talk about is the number one standard. And then blood gas would be like in our critically ill patients, but the average clinic does not have a blood gas machine. We have one at BCA, we have them at Purdue. We had portable ones that I could bring into surgery when I was at Purdue. So, I do blood gases more when I talk about horses, because you'll do a lot of it in horses. But let's talk about the basics, because remember, everything I'm talking about in monitoring, there's a machine that can probably monitor it, but then how do you monitor it? By your eyes, your touch. First, look at their gums. Look at their gum color. When I describe it to owners, if I have an ER patient or I'm troubleshooting, someone at home, I'm like, your dog's gums should look bubblegum pink. They should be pink like bubblegum. And if they're lighter than that, what does that mean? If it's, but we got to give them an idea of color. This tells us, are they oxygenating, and do they have adequate perfusion? If you have a good enough blood pressure, you hopefully will send oxygen or perfusion to the body and will achieve oxygenation. Now, again, your gums, the gingiva are the number one place, but you can kind of get an idea of the color of the tongue. Another one I really like is the lower eyelid. Like, pull this eyelid down. Is this really pale? Is it brick red? But obviously the prepuce and the vulva. Sometimes I've had cats that are very pale, and it was like a white cat, or they have like the little pink paw pads. Sometimes you can look at their paw pads and they look a little more pale, but that's not the best one to use. These are the ones. But what we're looking at, if they're pale, I want you to be able to tell me what that means. If they're pale, we either have poor perfusion, which could be low blood pressure, they lost blood, or they're anemic. So that's why animals get pale. Also, you might want to put on there hypothermia, because when an animal gets really, really cold, remember, their periphery here, all of that blood, they're going to constrict to conserve the blood at the core. So and let me also add something to pale. Dexdomitor or alpha-2 use. So if you have a dog that gets xylazine or dexdomitor, those dogs, that drug causes vasoconstriction. And so a dog on dexdomitor could be very pink, and then you sedate them, and then they look extremely pale. That's an effect of the drug. So when you guys especially do radiology too, rad 2, whoever's the anesthetist, and I tell this to every class, every time, and I will always get somebody kind of panicked, which, I mean, you're concerned, which is good, but I'm like, you gave a drug that's going to make them look pale. Unless they bled out on the radiology table, and you're going to probably have blood work on that dog and confirm if they're anemic, but if they were pink to begin with, and you sedate them and they're pale, that's because of the drug. Okay, so that's because of the drug. So that's pale. If they're cyanotic, which can be blue to purple, or sometimes looks like this dusky pink, call it like a dusky pink, very scientific, but they just are like a little shades of blue to pink to purple. Now, respiratory arrest, if your animal's not breathing, could be they're deprived of oxygen. Now, deprived of oxygen, I'll give you an example. When you guys are sedating these guys for radiology, they are not on oxygen. They are breathing room air. But a normal animal, even sedated, even respiratory depressed, should not be blue to purple. Even if they're sedated. They can be pale because of the drug. They shouldn't be blue to purple. So that means for some reason, the animal is not getting oxygen. Or do they have pulmonary disease? Do they have pneumonia? Pneumonia blocks oxygen from being diffused in the alveoli. So they are inhaling. I do a chart. We're going to be doing like a pulse oximeter troubleshooting thing. And it's basically like, where's the problem? Is my dog not getting oxygen? Is he getting oxygen and it's a mechanical issue, or is he not able to use the oxygen? If it's a dog with pneumonia, it's not that he can't access oxygen, he can't use it. So that's how the mind has to work. So the other things that affect mucous membrane color that interfere, I told you body temperature. They're going to look falsely sometimes pale. I mean, they shouldn't be like white as a sheet. You know, they're just going to not look as pink. It's like the gum you've been chewing for a half an hour or an hour. It's like you chewed out the color or whatever. Vascular resistance, which means vasoconstriction. If you have vasoconstriction, which kind of leads into body temperature, or a drug that caused vasoconstriction. The other thing is, let me add a color that's not on here. Brick red. If you have a dog that's or we call them injected. Hopefully you learned that when you've done physicals or whatnot. But if we have what's called injected mucous membranes, they look like they're inflamed or they're very red. And you push their gums and it comes back in like a millisecond. It's like you push it, it's like, so we can have, not that we have overperfusion, but dogs that are in septic shock, sometimes they're hyperthermic, so they have they have a fever. If they have like a septic abdomen, sometimes those dogs came in and they were, if I see that, I'm thinking toxic. A lot of our septic abdomens that have maybe a ruptured intestine and they come in for emergency surgery. Sometimes those dogs are very injected mucous membranes, and that's because of the peritonitis, and it sets up this whole inflammatory syndrome. But again, gum disease, a dog that has very bad gums with bad tartar and their gums are red or inflamed, they're going to look more red. So if I've got a dog that has like a really gross mouth and their gums are really bright, I'm like, well, it could just be because the gums are irritated because of the teeth. So you just have to evaluate the situation and the animal that they're in. But again, looking at the beginning of the animal to where we are. Now, if you're thinking about, got to get into physiology, is every cell, every tiny little cell needs oxygen in the body or cells die. So that's what we're trying to maintain. There is two types. This is an important slide. This is slide 49. There are two different types, or there's two ways oxygen is carried in the blood. The one you're probably the most familiar with is the second one, is oxygen is bound to the hemoglobin on a red blood cell or an erythrocyte. When an animal inhales oxygen, it will bind to hemoglobin, and when the red blood cell goes all over the body, it drops off. Remember in anatomy, I was like, it's like a little car. The red blood cell's driving it, it's like dropping off oxygen, and then it picks up CO2. As long as oxygen can bind to hemoglobin and it can be carried to the tissues. Now, that's perfusion. You can have oxygen that binds awesomely, and then you have really crappy perfusion and the red blood cell isn't going anywhere. Doesn't mean I didn't have oxygen. Do you see what I'm saying? I had oxygen. It just didn't get transported. But number one is oxygen bound to hemoglobin. That's standard. But there is also free oxygen that's dissolved in the plasma. And that is minor. That's why I'm not like, I always focus mostly about hemoglobin binding, oxygen binding to hemoglobin. But there is oxygen dissolved in the plasma. So we've got two components of how oxygen is carried. Normal oxygenation, you can't go above 100%. Okay, your dog is never 120% oxygenated. As long as they're 100%, that's great. I always say 95 to 100% is normal. That's kind of like a standard across species. That's everything. If your dog, your cat, your gerbil, your horse, your cow, 95% and above is what they're supposed to be. And what 100% means is that every hemoglobin that's available is saturated with oxygen. It means it's bound. I will tell you, for me, which is weird, almost every time I go in, I'm literally like 96%. Sometimes, like one time I had it on my finger and I started to try to breathe deeper and more often and I hit 97. But I've been like that, you know, almost every time I go. So I don't know, but as long as, our goal is to be 95 and up. So now there's a little note here at the bottom. PCV is an important determinant of oxygen availability to the tissues. I've said this before. People that are anemic, one of the main complaints of people that are anemic is they're tired or they get winded easily. They can just do minimal activities and they're breathing harder. It's because if you are anemic, you do not have enough red blood cells to carry oxygen. So anemia can be a factor in oxygenation. You have to get to the root. It's not like, oh, my dog has crappy oxygen, let's give it a blood transfusion. I mean, that's, if they're anemic, maybe, or if they've lost blood, but that's, so that's a common complaint. Now, you guys aren't going to have to calculate this. Don't worry about that. But there is a way to measure this. But what I want you to know is this thing right here where it says PaO2. PaO2, which is partial pressure. That is what measures our unbound or dissolved oxygen. And it is in millimeters of mercury. So right now it tells you 80 to 120 is normal. But this number has to come from an arterial sample. The way I tell students to remember it, it has an A for arterial. That's not what that A means, but if I was taking a test, that's what that A means. PA is for partial. PaO2, and when we measure PaO2, we're measuring dissolved oxygen. Now, it says you can get it from venous blood. If you can't hit an artery, we can get a measurement from venous, and it'll sometimes give us an idea of what arterial would be. But this normal that's written here is arterial. But the reason I'm saying this is there's an 80. And I've already told you 95 and 100% is normal. That's for the little light on the finger. PaO2 is a different value. It is highest in arterial blood, lowest in venous blood. That is basic physiology. Arterial blood carries oxygen, venous doesn't. Sometimes when you go to hit an artery, and I've sometimes hit a vein, they run right together. So sometimes I've been aiming for an artery and then I accidentally hit the vein and then we get the value and it's like 60 or it's 50 for mmHg. And my boss, one time I did it, I'm like, oh God, this guy's oxygen's really bad. And he's like, well, he's somewhat pink and he's alive, so you probably hit a vein. And I was like, oh. And when it came out, it was a little darker, but I've been fooled before. So I was just like, oh, okay. But that's an indicator. That's why oxygenated blood is nice and bright red, because arterial blood, because it has oxygen. So what scares you, Michaela? Everything. No. All this blood pressure stuff. Now, as there's SaO2 and PaO. Oh, that math. Yeah, no, I'm going to tell you, I've never had to calculate that in my life. And I did blood gases for 7 years at Purdue. I got a little machine. I slaps out a little piece of paper and I'm like, Doc, here you go. So I've never had to calculate it. There's more important math you need to know, not that. Now, percent saturation, SaO2, is telling us how much or what percent of sites are bound by oxygen. Okay, that's SaO2. Because you have an A here, that's still arterial. So when I do a blood gas, I look at the PaO2 and the SaO2, and that tells me how much oxygen is dissolved and how much oxygen is bound. But because there is an A, this is not SpO2, this is SaO2. Again, highest in arterial blood. This one is telling us how much hemoglobin is bound. Now you'll see this number is in a percent, because we're like, what percentage of sites are bound. So we're giving us an over, and so this is, you know, normal will be 97% and above. So this value is, I mean, I'm going to tell you, if it's 95, the doctor's probably like, that's adequate. So this is similar, but the thing that I want you to know is that they're accessed arterial blood or being estimated. And I think everyone, a lot of people know this, but room air is only 21% oxygen. When we're breathing right now, it's only 21%. When you have an animal on anesthesia, they are breathing 100% oxygen, okay, when they're intubated. If you're holding a hose in front of their face and they're breathing oxygen, it's harder to, you're putting 100% oxygen in front of them, but they're getting some room air. So they're probably at somewhere like 70, 80%, depending on what they're accessing. But I'm just giving you an idea. When you start to get your PaO2 on that low end of 80, then this is going to start to drop very fast. But we're going to get into that. It is not a linear, and what that means is it doesn't follow a direct line. What happens is, as your partial pressure decreases, which is your free oxygen, your saturation is going to decrease, but not as rapidly. But what this is telling us is this partial pressure is taking oxygen availability in an animal with normal hemoglobin. So that's why we measure partial pressures and oxygen saturation from arterial blood, is we're saying how much oxygen is available for the animal to use. Now, one thing to understand is the relationship of low hemoglobin. Now, sometimes that happens in anemia because we don't have enough red blood cells, but we can't look at one or the other. You can't just look at hemoglobin and say, my animal must not have adequate oxygen. That doesn't always happen, but it's something to think about with an animal with low hemoglobin. But occasionally, there is not enough hemoglobin to carry oxygen, and this is when you would start to potentially see the clinical signs, or you start to get the abnormal values. This is what is interesting. When you put an animal on 100% oxygen, say from an anesthetic machine, or put it in front of their face, the dissolved oxygen will increase because they're inhaling that and it's dissolving, but it doesn't always improve our saturation because that's a hemoglobin issue. Do you see? So if you have a hemoglobin issue, you can give them more oxygen and it'll improve. But remember, I said dissolved oxygen isn't our major oxygen component. It'll help, but we need enough hemoglobin and we need the oxygen to be able to bind to achieve the best oxygenation. So that's why it's saying it marginally affects the total content. It'll help the dissolved stuff. Okay. Now I'm going to tell you what I've just said. Measuring PaO2 and SaO2, because both have an A, they are arterial. You put them in a special blood gas analyzer machine. That's what measures partial pressure. Pulse oximeters only give us percent saturation estimates. These numbers should always be elevated if your animal is breathing 100% oxygen. Because obviously, if you're giving 100% versus them breathing 21%, you expect that number to be higher. If you have these numbers are low during a blood gas, it can indicate hypoxemia, which means they're not getting enough oxygen. And you either have to give more oxygen or potentially assist ventilation. You're going to push the oxygen in. One of the issues with COVID-19 or people that are on ventilators is that they've tried giving these people oxygen, just like a face mask or the nasal cannulas. It's just not getting into the lungs and not getting perfusion. So that's why they're putting on ventilators to try to increase or force the oxygen in to see if they will use it better. So that's just a kind of a modern day, why do they put people on ventilators? Okay. Now, this is important, and I'm gonna stress, I wanted you to understand those values because when you look at things in a book, you'll see those values. Pulse oximeter, I want to say almost every clinic has them. If you've seen them, sometimes they're in radiology. If you've been in surgery, they have a little portable one, and it sits by itself, and you can just clip it on their tongue, lip. I've put them on the prepuce. I've put these little things, anywhere, sometimes on a little fold of skin. We'll talk about that. But this is an estimation because you're putting it outside the body. It has to shine usually through a mucous membrane. So usually the tongue, the lip, I've sometimes put it in a toe web. Like if they're big enough, I put a little alcohol there and I try to put the probe on. But it is an infrared light. And what it's doing is the light, you'll see there's a red light on one side, okay? A little tip, when you put it on a tongue, make sure the red light shines from underneath because sometimes the red light's shining through the rough part of the tongue. Sometimes I'll get a weird value, I flip it around and I shine from the bottom because it's smoother and I get a better reading. But normally they're going to be 95% because they're breathing 100% oxygen. If you get a value between 90 and 95%, we're starting to have a degree of hypoxemia, which means their oxygen is dropping for some reason. If they are 90% or lower, there needs to be intervention or therapy, like ventilating the patient more often, which is like squeezing the bag or putting them on a ventilator or trying to maybe turn up your oxygen. I will tell you, turning up the oxygen doesn't fix things automatically. You will learn my biggest pet peeve, and the old marches who are getting ready to start surgery, they hear me say this over and over. Every time I ask a troubleshooting answer, I have a student tell me, turn up the flow meter, just turn up the oxygen. It doesn't magically fix anything. If you turn up the oxygen, you probably have to squeeze the bag. Just turning up the oxygen isn't always going to force the oxygen in. But everybody just likes to say, turn up the flow meter. I finally said to class, I said, if one person tells me to turn up the flow meter, we're going to step out in the hallway. And it kind of became a joke with us because, one person, the student said it, they're trying to be funny. They're like, should we just turn up the flow meter, Miss Landero? So I was like, I'm going to take you out in that hallway. I was like, don't say it. I'm going to get into ventilation. You got to squeeze and push in the oxygen. So when you start seeing those values, and I'm going to tell you, 85% that's holding for like 30 seconds to a minute or more is a medical emergency. Because what's going to happen let me see if I can do this. I'm trying to be fancy here. Where's my whiteboard? Where'd it go? Okay, can you guys all see this or did I completely just go? Okay, cool. All right. This is my fancy, whoa. Okay. Now what's going to happen, when a pulse oximeter starts to go down, like if your reading is starting to go down, it kind of starts to go like a nice little ski slope, like here, and it goes down. Once it hits 85, it goes like that. So you expect, okay, it's 85, 80, 74, 70, 62. It's pretty much like 85 and then it's like drops off a cliff. So this is why when we are troubleshooting, we really gotta, we're getting in the 90s and the 85s, we really have to, we gotta do something about it. Did I go away? Oh, hello everybody. Oh, are we here? Wow, my computer just did really weird things. Okay, so what I'm trying to say is you have to really be paying attention so that it doesn't fall too rapidly. Now, this has always been confusion for, there's been a class and we went back and forth about this. The absolute lowest is 85%. When I'm at 90%, I'm very concerned. But, you know, if students are like, what's the absolute lowest? So some people would put 90, some people would put 85. 85%, you don't want to fall before. If we're at 90, we have to start doing something to get intervention. So 85%, I want you to know, is your absolute lowest that your pulse oximeter should go. Okay. Now, the other thing too is of course I'm anesthesia. We will put pulse oximeters on animals that come into the ER. I put them on, try to put them on their lip while they're recovering, because sometimes doctors are like, check their oxygen levels. It's obviously, I can't put it on their tongue if they're awake. Put it on the lip, a prepuce. So we do use it for awake patients as well. There's a couple different types of probes. There's a transmission or a reflective probe. The transmission probes are probably the ones you see the most, and they look like a clothespin. They've got two pieces and it's like a clamp. One is the light source and one is the sensor. That's like, it doesn't shine a light from both sides. So when I troubleshoot with students or they're getting a reading they don't like, one of the first things I look at is the light shining the right way? Again, like for the tongue, let's say you put it on the lip, okay? You're gonna clip it in the lip. You don't want the lip shining through the fur side. You want the light shining through the lip side. So that's what I'm saying. Like if you're getting a crappy reading, how did you put the probe on? Okay, is the light shining the right way? Now, normally you don't want it to be on pigmented tissue. If you have a black chow, well, it could be a tan chow. Most chow chows have black gums, even black tongue, which will impede light flow. So you have to try and find an area on them that is not pigmented. That could be the toe web, the prepuce. So I have tongue, pinna, sometimes the pinna, the vulva fold, Achilles tendon. If you've ever seen a greyhound or a whippet that's super thin, right over the hock, I've sometimes put it over that tendon because it's really thin skin. Sometimes I've put it, their skin fold. There was just a picture, and I think I shared it on the old Marches page because they're getting ready to start. It was a bulldog, and they had it on one of the folds on his forehead. They had a pulse oximeter. I mean, I've sometimes put them all over places to try and get a good reading. These are going to be your gold standards that I want you to know for the test. If you cannot use the tongue, or you've got black tongue, black pigmented lips. But what's going to happen is the light shines through. You still see the graph? Do you guys still see the graph? Oh, I don't want to do that. Why did I do that? Hold up. Well, what happened to my... Hang on, where's my notes here? Now, hang on. Let me do this. Okay, you're going to have to look at my whiteboard because I don't know what's happening. Can you guys see this okay? Okay, you're looking at me, so I'll ask you. Okay. Sorry, Caitlin, I don't know why that's happening. Okay. Okay. But you can see the PowerPoint, even though you can see the whiteboard. You can't see the PowerPoint? Okay, let me hang on. Well, I stopped recording for a second because all that nonsense was going on. So I just hit record again. Thank you for telling me that. It's Tuesday, but it's Monday. Okay. The reflective probe, the light, it looks like a paddle, okay? It's flat. It doesn't have a clothespin. This can be placed in an organ. So we can slide this probe in, so it's not that clothespin. This would be shining up on something. So you can put it in the esophagus. More often than not, we usually put it in the rectum. Now you can slide, they make these little sleeves that are clear plastic that go over it. I have put them directly in the rectum and then I just clean it later. But the key here is the light side has to be facing up against the rectum. If you put it face down and there's feces, it has to touch the inner lining of the intestinal mucosa. Okay, so you got to think about how you're placing it. Okay, now, so if you have a patient where you can't do the prepuce, you can't do the tongue, our monitors at BCA came with both kinds. They came with the clothespin and they came with the reflective probe. So if I had to switch because of the surgery, I could put in one probe. Now I'll tell you, 95% of the time you're going to use the clothespin one, but you can use these in a hollow organ and the light is reflected into the sensor. But obviously when I talk about troubleshooting, I'm going to be talking about if it's in the rectum, I don't want to know the pulse ox of their stool because it's kind of shitty. Okay, sorry. I know, was that inappropriate? Don't report me to anybody, okay? Keep my job. Michaela, do you like that one? No. I told you, I know I've had some really, I've had some really crappy readings. I can just keep this going. Okay, good. Hopefully we needed a laugh. No, but to be all honest, let's keep going. I've pulled out the probe and someone's like, oh my gosh, my reading's really bad. And we pull out the probe and it's covered with stool. I'm like, okay, let's wipe it off and then we'll reassess. Are we really concerned? And a lot of times you clean it and then put it back in and it's normal. This is the clothespin. So you've got the clothespin, that light would be shining underneath that tongue, okay? So it's gonna be underneath, and this is a little portable unit. The numbers you're looking at, and it's hard to see this, 97% is the saturation. That 97 is saturation. Now 70, this is called a pulse oximeter. Pulse oximeters will usually give you a percent saturation and a pulse because they're on the tongue and they're measuring off of the mucosa and they will sense the pulse. So that's the nice thing is you get two values with it. You get a pulse of your patient and you get the oxygen saturation of your patient. Now, here are some of our other creative measurements. See here, we have it on the pinna, but I'm going to tell you, you're not going to get a good reading if you have the light side on the outside of the pinna through the fur. You want the light shining through the inner pinna. And then here they've used that reflective probe. They actually have it placed, it looks like in here over the hock or the tail base. The green one here is right under the tail. There is a ventral, I haven't done this one, but there isn't a tail artery. Real close to here would be the rectum. And you can play it under there. And then the blue dot, here's between the toes. So we're in that toe web. You can also see that blue dot, that's at that Achilles tendon. I've had that work on cats, dogs. That's kind of a good spot that Achilles tendon, because you can't always access the prepuce and the vulva. And this is going to be accurate if I put the tongue probe on a prepuce and a vulva. I'm going to want to clean it really well, because I usually just take alcohol wipes, clean it, and then it's ready for the next patient. You can use alcohol to clean. You don't want to use alcohol to clean a Doppler. You have to be careful because that's a sensitive crystal. These, that light sensor, you can wipe it off with alcohol. Because there's nothing worse than going to grab a probe and it's yucky. Okay, this is a very important slide, number 60. This is why you get low pulse oximeter readings. Okay, incorrect use, just like I told you. You have it shining on the outside of the pinna, and then you get all panicked because your pulse ox is 90. And then I walk in there and I flip it around and I get 97. Okay. If you have a dog in radiology vasoconstricted because of dexdomator, if they're vasoconstricted where you're putting the probe, sometimes you can get a low reading. Now, I've gotten good readings on dexdomator before, so that doesn't always pertain. But if your patient is very pale and you have the probe there, it could be a problem. If you do not have adequate perfusion, and I've told you, why do you not have adequate perfusion? Can be because of vasoconstriction, can be of low blood pressure, can be dehydration. Do you see how all of that can cause not adequate perfusion? Inadequate oxygen delivery. So your tank runs out of oxygen. That has happened to me in surgery. You guys have to watch that really close. When you're in surgery, there's those little green tanks you probably never noticed under the anesthesia machine. It's a little oxygen tank. But the problem is those can run out. Now, we always have a backup on the machine. There should always be 2 oxygen tanks on the machine. So you have your one in use, and you should always have a full one. But if that runs out, now this happened at Purdue where, all of a sudden I look over and the patient was starting to breathe weird and the anesthetist got concerned. And when I looked at the machine, their oxygen flow meter was off, or it was down. I'm like, you're out of oxygen. So right now your patient is breathing bad because they're trying to get oxygen. Inadequate ventilation. So it can be the animal isn't breathing, they're not breathing enough, or they have inadequate circulation. Okay. One thing, let me give you an example, and we're going to end on this slide, but tomorrow I'm going to show you the chart, the troubleshooting chart. Think of it this way. I had a dog. I was first starting out before I went to school, and my boss told me, or I was trained to be, what's normal, and the pulse ox was reading like 90, 87, and I was like freaking out. And I was like, oh my God, I'm like, his oxygen's low and I'm concerned and blah, blah, blah. And my boss looks around from surgery and he goes, well, maybe you should get the probe off the floor and put it on his tongue. And I was like, it's on the floor. Now, someone said, oh, they were impressed that it was even 87 to 90 on the floor. Sometimes when it falls off, it doesn't just go to 0. Sometimes it's kind of still at the reading. Now, sometimes what happens, these probes, you put them on the tongue and they start to slide to the tip of the tongue, or all of a sudden they're like hanging off the very edge of the lip and they might fall. But that taught me a very important lesson, because I was like, maybe before I alert my boss to a problem, I should check the probe. It's one of the very first things I tell students. If you have a crappy reading, the first thing that you need to do is check where the probe is. Because if it's on the edge of the lip, if it's slid off the ear, if you have it flipped the wrong way. My rule of thumb, if I get a pulse ox reading that I do not like, I usually move it to 2, or I move it 2 or 3 other places. And if I get the same reading 3 times, now, if I have it on the tongue, that might mean I move it to the other side of the tongue. Think about this. If you put a clothespin on your finger and you held it on your finger, wouldn't it start to blanch out your finger? Your finger would start to turn white because that pressure would hold and hold. So sometimes if the surgery's long and it's been in one spot, it blanches out that spot and it prevents blood flow sometimes to that spot. That's why sometimes I take it off and I rub the tongue. Like I take off the probe and I kind of like massage the tongue. It's kind of like if you had a clothespin here for an hour, you'd probably be like, all right, let me get the blood flow back to my finger. So sometimes, but spay and neuters should be quick. Some of my surgeries were 4 to 6 hours long. So it's like I'm constantly moving it because perfusion or whatnot. But if I moved it 2 or 3 other spots and I kept getting 92, 92, 92, I'm like, okay, I've moved the probe. Sometimes I've cleaned the probe. I wipe it off with alcohol because I'm going to tell you, if the person before you put it on like a bulldog or like a bloodhound and it had a bunch of like dried mucus on it, dried like saliva, the light doesn't shine well. So sometimes I just wipe off the probe and I put it back on the tongue, back to normal. So I clean the probe, I move the probe. Okay, now obviously if your patient was showing like a super weird ECG or they were starting to breathe very strangely and you get this reading, you have to kind of do this fairly quickly. I'm not going to spend 15 minutes. I mean, I can troubleshoot the probe pretty quickly. Is it on the floor? Is it dirty? If it's in the rectum, is it in stool? Do I have it placed upside down? Is it plugged in? Right? So right now, one of the first things is like I check my probe. After I check my probe, the next thing I'm going to do is probably check my oxygen. But I want to stop there because we're going to make a little list. I know we're going to go to, you're totally fine, Haley. People forget to type here. But the reason I want to stress this is because almost every clinic will have a pulse ox. It's not my favorite because it can give you some false readings, but and students freak out, or people first out in practice sometimes freak out. So I spend a lot of time talking about a pulse oximeter because I'm like, you're going to have to determine, is that true? Do I believe it? And when you get a crappy reading on monitors, everybody likes to see everyone goes, it's just the monitor. I'm like, are you sure? This is all troubleshooting we're building. I'm like, how are you going to determine that is correct versus it is a probe issue? Because a lot of people like to just blame the machine and leave it alone. I'm like, well, there's things that you can do to try to figure out. You don't just go, oh, it's crappy reading, whatever. Hopefully my patient will live. No, we are going to build a list so that when you guys are in surgery, in radiology, you'll have a pulse. That's the only thing you'll use in radiology. All you'll have is, well, your stethoscope and you, but the only monitor will be a pulse oximeter. So I'm going to stop there. Sorry if I froze. Sorry that whole whiteboard and like my Zoom seizure, that'll be it'll be interesting for the video. You can just like you can zoom through that part. Man, I'm full of it today. I think I'm going to end right here. If you have questions, I've changed for those of you that got on a late. The homework is not due until Friday. I will put that in the email, Comedian Lando. I crack myself up if nobody else. It's still a little bit of my sleep deprived. The puppy slept from like 12:30 till he's done twice where he slept till like 6:30. So, but still, you're constantly running after him. You're on guard. It's just making me exhausted. A new Netflix series. Yeah. Oh, I don't know if it'll be very well watched, Michaela. Probably not. Okay, well, I'll get this video converted and I will send this one with the one from Friday, the proper link, since I guess the one was a duplicate, not valid link. All right, if you need anything else, I need to go relieve my daughter and check on the puppy. So I had to wake her up and bring her downstairs. She's like, I need puppy duty. So, all right. Well, you guys have a good day. Thank you. Bye. Bye bye.